You're live. I've got us live. It's good morning, and it's Tuesday, April 14th. This is Central Health and Welfare. We're looking at H611. And Senator Jewett, one of you, see anyone wants to.
Okay, we're looking at H611, and we will be hearing eventually from Ledge Council and Alex. But in the meantime, are there some folks in the room who would like to speak on H611? Okay, we have Mike Fisher and Devin Green. Let's see.
I just want to recognize you, but Devin and I have just fought so much this year. With this special moment.
Are we gonna literally hold hands?
No.
That
was an olive we're gonna do.
Don't worry, we'll fight again later. But today we're coming together with the concept.
Devin Green, Vermont Association of Hospitals and Health Systems.
Like to share about your
And we're coming together with a concept with the caveat that we don't understand the implications to DVHA or Medicaid at this moment in time, but we are hoping that it is streamlined enough and easy enough that we can implement this pretty quickly. But what we're looking at is right now, Medicaid is doing a hospital global budget pilot project where a couple of hospitals are having a global budget for Medicaid, which means the Medicaid pays them a certain amount, and that is their budget for the year, and they work within them. Because that's their budget for the year, they take on a lot of risk when they do that. In thinking about this, one of the tools to mitigate risk that payers have is prior authorization. Prior authorization is a huge administrative burden for hospitals. I will say that DVHA has worked hard to streamline the prior authorization process, and we appreciate that. But previously, under the OneCare model, what DVHA did was they had a sort of prior authorization waiver. Most prior authorizations, providers did not have to do. It was very, I think there are reports, and we can submit those, that show that it was pretty successful. We would like DVHA to implement that sort of waiver of prior authorization in this Medicaid global budget, because the hospitals are taking on the risk. There's no real need for prior authorization if the hospitals are taking on the risk. They're not going to do unnecessary MRIs that cost money when they will have to pay for them. And so they're just looking to ease their administrative burden and reduce costs by having a very, very, very reduced prior authorization process. I think what would still be in play are things like durable medical equipment and some other sort of clinical safety issues, but otherwise it would be very streamlined. And we're just trying to continue the good things that came out of OneCare into our next payment reform efforts.
So just to say it again, in other words, the logic behind why the Medicaid prior authorization exemption for OneCare is identical to the dynamic in the global Medicaid global budgets. And not only is it good for providers, it's good for people too.
Yeah.
And it should be good for Medicaid as well. So that's the concept that we wanted to bring to you. And there is language floating around, and I think Devin just said this. We have not talked to DVHA about what the implementation would be, how, I mean, they did just do it. Let's just remember, they were just doing it last year for OneCare and Tribune Lives. I'll add another sentence. There were things that were tricky in the OneCare context because it was lives that traveled around. This is simpler. This is care happening at the hospitals. And so it should be much easier for everyone to understand what they. We had fights, particularly with Dartmouth for some reason, about, Dartmouth would say, this needs a prior authorization. We would say, no, there's no prior authorization. You need, and we would say, we're not doing a charity with a prior authorization. And those kinds of things would.
So what you're suggesting is a new section in the bill that would have the prior authorization continue as has been in the ACO. And this is put as I asked this question earlier in January, but we weren't losing this. So I'm glad to hear that it's beneficial to both the people and hospitals.
And I'll just say that the prior authorization exemption in the one care model was it should be, from our perspective, a good thing.
So my question of you is language. And so Jen is not here, unfortunately, but I'm sure she will be able to put something together for us.
We sent some language to Jen, and I think we would like sometime to discuss with Diva a little bit about the specifics and make sure that we get that language right.
So, when you send it to Jen, did you copy me? Okay, good. We'll look at it and then, I'm sure she'll be reaching out.
I have just a few questions here. So as I understand this, the hospital would receive payment that would cover their Medicare cost for the Medicaid.
Okay.
That makes sure I got the right one. And is that on a patient basis? Is that on just the hospital basis? How is that determined? Here's how much they receive.
It'd be really good to have medication. I'm sure.
There is, I would have to go back and look at the exact way that they are, implementing it. I think it is looking at the hospitals, previous, I'll have to go back and look at it. And
Just trying to figure out how
Yeah.
that works. And then if the hospital gets towards the end of their fiscal year and their costs have exceeded what it is that they had expected to be, what I see happening is a couple of things. Cost shifting. Because the hospital still needs to somehow get paid for trying to limit the shipping. So I worry about those things and how those would work. In the perfect world, it should work fine, but I can see where, for some reason, the number of patients or number of treatments ends up being more than what they have seen in the last, what they had figured out.
I think it's, so Medicaid is experimenting with this. There's a handful of hospitals that are experimenting with Medicaid on this. I'm sure these are the details they are figuring out in this pilot. And we are just adding the concept of prior concept.
It's an existing concept, and I think everyone shares your concerns around access and sustainability of the hospitals and risk and everything else, but the hospitals that I've spoken to feel like it's going well so far. And I know that there's Medicaid is thinking about the access piece and that it's more than just here's your money. That's it. I think there's some safeguards built.
Thank you so much.
Yeah.
It's really beautiful. If we could have Jennifer.
Here, and Alex is to be up on the screen.
Alex will be able to
Answer
screen,
questions.
answer questions.
And now they ask him to talk about it.
Okay, but ask them about that, yeah.
Right.
Okay,
That's perfect.
hi, hello, Alex. Good morning.
Hello, good morning. Thank you for having me and accommodating me virtually today. I also want to say I will try not to get too distracted by the adorable unicorn on your table. I think our 4-year-old has the same one.
We like our unicorn. Alex, we're wondering if you might be able to comment on the discussion that we just had around prior authorization.
I can comment very briefly. For the record, Alex McCracken, Director of Communications and Legislative Affairs for the Department of Vermont Health Access, and I use she, her pronouns. This conversation has just very recently come to the department's attention as of this morning, so we don't have a very well-prepared response, but I can say from the top level that if the committee is interested in pursuing this language, I would highly recommend having Alicia Cooper come in and talk as our subject matter expert on hospital global budgets. Generally speaking, what is being proposed would require a pretty large systems change because the structure of this model is very different from the ACO model with regard to PA interactions. So we would really encourage the committee to hear more from Alicia Cooper and the DVHA side. And also we will happily work with the hospital folks on this language. We understand the benefit of the prior authorization waiver from the ACO, and it's something that we're interested in pursuing any avenue that we can to alleviate provider burden. But this would require a pretty large lift from our end.
Okay, thank you, Alex. We will make sure that we reach out to Alicia Cooper and have her in to testify and have a discussion about this. Thank you. Alex, what else did we want to do, Alex?
This Alex is gonna be available.
Okay, for questions, you'll be available for questions. Great, thank you, Alex.
Yes, I'll be here. Thank you.
Jen.
Good morning, Jen Carter from the Office of Legislative Counsel. I believe you are planning to do markup.
Yeah.
So I can put the bill up on the screen. That would be helpful and we can look at it together. See where you might want to make changes. Okay, so this is page 611, an act relating to miscellaneous provisions affecting the Department of Vermont Health Access. It starts off by making some changes in the existing statute on prescription drug cost transparency that would remove DVHA and the Medicaid prescription drugs from what's reported to the Attorney General's office as far as drugs that have recently experienced a significant increase in wholesale acquisition cost. The stated rationale was just the very different prescription drug pricing in the Medicaid program because of the federal parameters, and so the lack of perceived utility of this requirement.
And just so, while we're going through, I know we've had lots of testimony on this. There's something that folks have testified to, we should identify. I don't have anything ready.
I don't believe I have been in the room for a lot of your the testimony that you have received on this bill, so you don't have to tell me what you are interested in.
I don't speak.
Some things I did have, let's see, I did have, was here the last time you took testimony from Blue Cross, Healthcare Advocate, and others, but I think that was on a proposed petition. We do have proposed changes to this, to that section.
That section, I don't know if it was that section, but
I think as just as we go through the bill.
Yeah.
If we have heard testimony and there's a concern or an improvement or an okay, feel free, I think we should each bring. Because I know you weren't here. Right.
All right, the second section deals with 340B drug pricing. And I think not specifically on the language that is struck here, but relatedly, you have a proposal from 5 states around adding some language to the existing subsection B that you can't see here because of the asterisks, but that is 18 VSA 4682B. And adding in a reference to 340B covered entities in addition to contract pharmacies.
Yes. I mean, we should probably, why don't we put that in a motion?
Do you have a spare one?
Or,
All right, I was just gonna ask Leslie if you print one. Have your notes, you go, I don't take yours. I get it. Sorry, this seems to be one I didn't print as it has my house version for my. Easier if I can write them as. Thank you. All right, but I can make notes. Okay, section 3 is, has to do with the makeup of the Medicaid and Exchange Advisory Committee. And making a few changes, including specifying that the membership has to include individuals who are also members of the Beneficiary Advisory Committee as a recent federal requirement. Making a few language changes throughout. Not sure if you've heard anything else on this. I'm not aware if you've heard anything else.
no, speak.
Section 4 is removing the reference to employees of small employers from the reflective health benefit plan statute, because that's really only a benefit for individuals. And now that you have a separate individual small group market, so strike the reference to employees of small employers. Section 5 makes some updates to the Clinical Utilization Review Board, putting the potential for it to have more than 10 members, getting rid of some outdated language, and allowing some more flexibility around board member terms. Thank you for anything on that.
Yep.
Section 6 has to do with the calculation of household income for the bee farm program. And this was delete language talking about household income being calculated using modified adjusted gross income. So those are the going to be user.
Yes.
Keep going.
When you know, I'm just like,
Oh, here. Just,
no, it's fine. Just moments. Just.
you're gonna get your hands all.
I know.
Yes, you'll have a picture of this.
Oh, yeah, the printer, there's all.
We,
Sorry.
yeah, a new signature, I think. With that, we're gonna throw tea in the
That's a
water.
lot of.
Yeah. All right, yep, I'm just gonna add my.
It's expensive.
What did we just do? Good.
We're good. I was just making my note right in the draft.
All right.
All right, yep, so that was the bee farm, income level or income calculation, which has not been done using modified adjusted gross income. Sorry, I missed that.
Oh, I just said, John, to take the printer to the chair.
Yeah. That closet. Where's that closet?
Section 7 relates to the increased amount that an individual would be allowed to have in a prepaid burial arrangement.
Yeah.
Without losing eligibility for Medicaid. Sections.
That's significant. It's like rich that we don't do it right now at the end.
Sections 8 and 9 relate to the Medicaid coverage for the state plan amendment for Medicaid coverage for doulas. I do think there was a suggestion.
Change
Change the date.
page of reference.
We push it back, right?
Well, this does push it back, but I think there was a suggestion.
There's,
I guess for A, maybe.
it's A.
Yeah, so,
It's, I'm sorry, it's for the OPR section. The
Right.
2026 and OPR
Yeah.
needs to be changed to align with the 2027 change.
That makes sense.
Thank you.
Thanks, Alex.
In both places,
Yeah. I don't see how we're going to be in effect.
All right. And that was it. And then the act takes effect in 2026. I think more what you've gotten is a number of proposal for additional sections.
Yes.
This is language that I am sharing that would just add some language to the bill that in the event the FDA approves psilocybin, that we would be able to, or I guess synthetic psilocybin, that we would be able to act accordingly.
So I've been having some communication with health department and my colleague Michelle Childs, trying to understand if this language is necessary. I think it's not clear that this language is necessary given the existing statutory and rule language around regulated drugs, but I don't feel like I'm the best one to speak to that. I think there were questions about whether it was, I was just communicating with them this morning about whether this would be necessary.
Who would make that determination?
I think you probably want to hear from Lauren Lyman at the health department.
Okay.
I don't know if you guys have a take on this or if you're even following. Yes.
Yeah, Jessica, can you let us know what the decision is? Or let Jen know?
Well, I don't know if you have anything to add at the moment.
Yeah.
Jessica Shafano, Department of Health. So we have, as Jen mentioned, been looking at this, and we do think because of the language in 18 VSA 4214 that adding this additional language isn't necessary. It would, if a drug becomes fully approved by the FDA, it wouldn't be subject to the prohibitions in the regulated drug rule. It would just be subject to any of the controlled substances, you know. It would be regulated normally as any other controlled substance would be in the state. So we don't think that legislative language is necessary to have that take effect immediately if the drug was to be approved fully by the FDA.
Is that the final decision or are you still looking at?
I mean, from the health department's perspective, yes, and we were looking to Ledge Council for some guidance on that, and it seems like, as Jen mentioned, and Michelle Childs did weigh in and confirm that interpretation seems to be accurate. So,
Right.
Yeah, sure. Lucy Guerin, on behalf of Compass Pathways. Our understanding is, because psilocybin is illegal both federally and in state, that it needs to be taken off the controlled substance list, which needs to be done legislatively. That's our understanding. I'm happy to talk with Michelle and the health department.
Okay, that would be helpful. Okay. I not do that. Well, they make sure we do it right. Everything.
Yeah.
The other piece that I know you had heard or had a request for related to coverage for the pre and post exposure prophylaxis for HIV prevention. There was, the language proposed was around, I think, both coverage without cost sharing and allowing pharmacists to prescribe, dispense, or administer these medications. You've heard testimony, I think, the other day from VFR about the language and the potential betrayal impacts.
I think I'm sorry.
I don't remember who testimony is from, but that pharmacists should
we keep allowing them to prescribe, but they're not given any compensation for these added duties. And there was a suggestion that they might be able to find a way.
And I thought, well, one, they were kind of, I think it was PrEP. It was basically getting covered, but yeah, when they supplied to the study, the report, I can't remember, so exactly, and that was the one that they were having the most part of it, I thought.
So the PrEP is already included in what is required to be covered under federal law without cost sharing because it has a U.S. Preventive Services Task Force A rating. PEP is not included
Right.
in the recommendations.
It's not preventive.
It's
An after it's.
Right.
Well, it is. It's post-exposure prevention, so it is still preventive, but I think it may be newer. So it is not, and so it is not currently required to be covered without cost sharing under federal law. I don't recall, look at my notes, I don't,
Which means we have to pay the full cost, right?
if you were to create a requirement to cover something that is not currently. That is not mandated. It was not either a previous mandate or required under federal law, then yes, the state has to defray. The increased premium attributable to that coverage requirement. And then what we heard from Sebastian the other day, which actually was not on my radars, and I've been looking more into that as well, is that the proposals from the federal government in the proposed payment parameters for plan year 2027 are considering requiring state defrayal for all new mandates enacted after 2011, even if they were in a state's benchmark plan.
The bombshell.
Yes, yeah. And it seems like that may, it may
Alex-
end up getting.
Alex has her hand up. Go ahead, Alex.
I don't mean to interrupt, but I would like to just weigh in here briefly on behalf of the department because we have not testified on this potential amendment yet. There would be a cost impact to Medicaid for this amendment. We do already cover PrEP and we do cover a lot of this without step therapy or prior authorization or the things mentioned in the bill. But the increased coverage, the expanding coverage would carry a fiscal impact and thus would require an appropriation. And there's a second issue that we want to flag around the second part of the language, indicating that shall not refuse, reject, or deny a prescription for any covered HIV prevention drug on the basis of the type or category of healthcare practitioner in regard to the pharmacists, I would believe. For Medicaid, we require per CMS that providers are enrolled in Medicaid. So this language would be problematic for us because we would need the provider to be enrolled in Medicaid in order to provide that coverage and reimbursement.
Understood.
Sorry to interrupt, Jen. Thank you, Alex.
I think I was most of that.
Sure. Yeah, would you like to say something?
Gail Zatz on behalf of the AIDS Service Organization, just a couple of comments. I don't anticipate that there would be a problem with amending that language to require that they are provided with that. In terms of the cost, I don't have information on the dollar amount, but we can look into that. And just to clarify, PEP has to be taken within 72 hours of exposure to prevent an HIV AIDS infection. So, so it is preventative on the post exposure. You have the dollar figure. I'm sorry.
You have the dollar
cost. No, I don't, but I can look. On that. I also wanted to let the committee know that the pharmacist part, I know OPR is interested in possibly putting that into OPR bill and sending government talks. I don't have that one of our table.
above our pay grade.
Yeah, I think.
Yeah, so that last provision,
Yeah.
in the amendment, for this committee would possibly not be in page 611. Just that last provision.
Right, that may end up moving forward in the GovOps committee in the OPR bill. So yes, I mean, I think if you were to proceed with some version of this language, I would want to make some amendments to the language that was proposed anyway, and it is, I think you want to understand the reason for that language that, that Alex was pointing to around the healthcare provider issuing prescription, or practice setting. Just because I'm not, this looks like language that is not necessarily Vermont specific, in its scope, and I'm not sure that's not a provision I'm familiar with seeing, I think, in almost any other type of, health insurance provision, so I'm not sure if it's necessary for Vermont. It may be addressing an issue that is not a problem in Vermont, or it's not a problem for the insurers that you can regulate, or plans you can regulate. But I think it would be helpful to understand what the rationale for that language is.
So why don't we look at the language, improved language for this, and then we need to know what the costs are, and Diva needs also to know.
Did everyone get that? But yes, okay.
So it sounds like there is interest in this language and you'd like to see it drafted the way I would suggest drafting in favor. Okay, yeah, I don't think we need to say anything about benefits being the same for covered spouse and covered dependents. Again, that's just basic in our insurance and health insurance laws. So I think there's some of what's in here that can come out. Other. We did hear from Blue Cross that they can't distinguish between the same prescription being used for prevention versus treatment. They have concerns about waiving cost sharing based on a diagnosis. But
Are we talking still here about?
Yes, still talking about PrEP and PEP. I'm not sure. I don't know enough about the medication, but I don't know if there are other uses for those medications other than this pre and post exposure prophylaxis. If not, then it sort of seems like that doesn't seem like a particular barrier. If there's only one purpose for which the medication would be prescribed, then it's not really an issue of what the diagnosis is. So medication was medication. Anything else?
Mike Fisher, healthcare advocate, about the prescriber, about the pharmacy prescriber, access to the pharmacy counter. I don't have a strong opinion about where that language lands. I do have strong support that it lands somewhere. And I guess I just wanted to articulate here that I understand that OPR has a process that they want to go through, and I want to honor that process. And I want us looking for some language that would move the concept forward through that process, so that we have a timeline for moving through that process and taking a step.
Right, time might also be.
Yes, and I think OPR, Jen Cullen from OPR had provided the chair and me with the language that they are looking at or have provided to Senate GovOps in connection with the OPR bill. In case you wanted to add it here, we could, their revisions would be appropriate for consistency.
Why don't we look at it then?
So I will include that instead of this language. It would be a separate question. Okay. All right, so it sounds like I'm not coming up with any other proposals. I don't think that you had heard.
I do have a question.
Except the one that you talked about at the beginning of your time together today. I'm not sure where you were with that. Well, on the prior authorization.
Oh,
We would like to add that. Yeah, we'd like to add that.
Then I think you're aware of what additional information I might need as far as scope of it.
Well, we want to hear from the district part, that generally we're in favor of.
Okay, and I had just had some questions that I sent to Devin to understand where and how I would draft it.
So is that prior authorization, that was just for the couple of hospitals that are doing it? Okay.
So there comes, have we talked about
Just that, preventive treatment. That's the one you wanted to make with no cost. I don't know that I guess what would the cost be if I'm not sure I want to wave a red flag in front of everyone right now.
As far as adding a mandate,
Yeah. If that is a real threat that we could get.
so I think that the red that we could get stuck with the cost of deferring all mandates exists, whether you add something now or not. It's just in the, it's in their, it's in what they're proposing for all states going forward. I have, in looking at some of the commentary on it, it sounds like there's a push to maybe move it to 2028, plan year 2028 rather than plan year 2027 because of the premiums are already well in development for plan year 2027. And I don't know if if there's a strong outpouring from the states against the proposal, maybe it won't end up in the final version of the rule, but right now it's basically the proposed federal regulations already been proposed.
Going back to 2011.
For all mandates, yes, required after 2011, regardless of whether it's in a state's essential health benefit plan. And that's the piece that is new for us, is that previously, or, as it's been implemented so far and based on the plain language of the statute, it has been, or the regulation implementing the statute, it has been only for mandates that are not part of the state's essential health benefit plan. So if it's not sort of your benchmark plan of what's already being covered and the state is adding something new on top where there's going to be new premium that there hadn't been for a premium for a benefit that hadn't been required to be covered in the past, that's what we would have to pay to Braille on. Now they're saying anything the state has required since 2011, even if it's in that benchmark plan, we would have to
Benchmark, okay, we agreed, we renegotiate with feds, right, to get it included.
So there are a lot of benefits that were in our benchmark plan because the way you got a benchmark plan was to pick from among several existing plans offered in your state at the time. And so our initial benchmark plan was the Blue Cross Blue Shield small group plan with the largest enrollment, I believe. In the state was the benefit package that became our benchmark plan. Then a couple of years ago, we were able to add a few new things based on a new federal opportunity that was made available. That's how we ended up with hearing aid coverage. Hearing was by agreeing with the feds based on certain fairly strict parameters that we could add something else. And so we did. So now our benchmark plan is everything that we had been required to be covered plus hearing aids. And so the rules had been, if it was part of your benchmark plan and already be covered, then effectively there was no new premium, even if attributable to it, because it was already being costed out in the premium. But if we were to add a new mandate that had a new cost attached to it, that's the part the state would be on the hook to pay.
So has anyone looked, Jen, at the mandates going back to 2011 and the potential impact?
That's
Jen,
what DFR said that, so when Sebastian testified
DFR.
last week, he said they were compiling a
haven't
list
been-
of those. premium,
Okay.
or those
This
mandates.
would be a raise.
So there, and there are a number of things that the state has done to kind of mirror what was required at the federal level. To safeguard against any changes at the federal level. And there's the potential that there would be financial exposure from that. Regardless of whether you add in is covered here. So that's what the federal process requires. That is how I understand. I don't know if anybody is different. Any stakeholders have a different.
Okay,
If I could just say,
Yes.
Fisher, it's incredibly frustrating. It is out of our control, but the EHB process included an analysis of richness of whether there's room within the EHB to add something like hearing aids. And there was, and so we did, and now the contemplation that even though it fits within the richness of our original central health benefit, we might get things for this. It's frustrating. And while I'm speaking, can I just also add, I know that the chair of finance often talks about grains of sand adding up. And so I want to recognize that. And I also want to say, with regard to HIV prevention, this is a very small population of people who really need it, and the investment is the right thing.
yeah,
Even
agreed.
if it's
Thank
on the
you.
state level.
Mike.
Thank you.
Great, so are we ready to move on to it was six, I think so, even though Katie's the. This Katie's one. She's on the. Okay, great, Katie's underway,
So any other comments?
6:11.
Jessica Shafano, Department of Health. I just wanted to note that the department has been in conversations with the OPR folks and other stakeholders about the pharmacist prescribing fees. And we're interested in ensuring appropriate access and uptake of this important treatment. But I think we're in the same boat of needing some more time to explore all of the different pieces and making sure that it's working the way that it's intended, and dealing with some of the issues that we know might arise to make sure pharmacists are being paid for providing these services, making sure that we have time to develop those protocols in collaboration with the stakeholders and figure out what the appropriate clinical pathway is for pharmacists to do it. So I think while we are supportive of the goal and moving forward on this, we'd like to have some more time to really figure out the details.
So in terms of time, our life is very short here.
Yes.
And the next time we take this up, I think we'll be taking it up to complete markup and vote. So that's the time we have. That could be as quickly as Friday, or maybe as quickly as Tuesday. Just that's where we are. We're gonna try and move as quickly as we can on these bills, which we have looked at quite a bit in the house, but I do understand that we're adding some stuff in here is different. Anything you can get us.
Madam Chair, too, I think the OPR bill is gonna be moving, coming up in the not too distant future.
Oh, you're right.
Are they this week or next week?
I think it may move this week, but there seemed like to me there's a timing issue that OPR had with it. Same thing that she just said, so, but I think they're gonna be looking at trying to move that OPR this week still fairly soon.
Great, to keep us posted on that.
I certainly can.
Thank you. Good to have you over there. Should we take a short break or?
When Katie comes in, we'll get back in. But Jen, do you need anything else?
I don't think so. I think I have some direction about what to prepare, and it sounds like for the most part, it's just adding on to the bill that you have, as opposed to taking anything.
And
Yeah.
Alicia Cooper and Jessica Shafano.
Yeah.
Those are, and others.
CC got work to do.
So we have
Gail's got
folks
to
to